Thank you so much for inviting me. And thanks to Olga for emailing me all those times, and to the AV team for setting me up. So, we're going to talk about implicit bias, but not, this is not going to be a talk about how to actually, like, it's not like a seminar on recognizing and managing our biases and things like that. Because of the audience of the medical education focus, what hoping we can discuss is using transformative learning theory, is a theory that informs my instructional design, both to inform the work and as an explanatory framework of how we can design curricula together to move toward health equity. And so I just need to set expectations now that it's not going to be like, oh, I thought I'd walk out with a skill about how to do this. It's about how to actually develop the curricula. So I have no disclosures. We're going to talk about a bunch of stuff. And the learning objectives, we're going to list 4 major components of transformative learning theory, describe the utility of transformative learning theory as a framework to guide instructional design and innovations for implicit bias recognition and management, and identify 2 specific educational strategies for implicit bias instruction that actually incorporate elements of transformative learning theory. And so we have a paper in Press in Academic Medicine using transformative learning theory as a framework for implicit bias instruction. And I think that it's helpful for some of the tougher, more potentially emotionally charged topic areas that are part of health equity. And so hopefully we can keep the discussion going. And so just so that we're on the same page, when we refer to implicit bias, we talk about it because it influences and contributes to health disparities. And this is through clinical decision making as well as communication patterns. And so in clinical decision making, the first study, at least that I read, that really got this conversation going was published back in 2007 by Alex Green and colleagues, and it looked at chest pain. Physicians looked at vignettes that were chest pain cases, and basically the only difference was whether the picture of the patient was a black man or a white man. And they also took the implicit association test, which we'll discuss in a little bit. And what the investigators found was that physician racial bias, right? Their racial unconscious bias, nothing being done on purpose, nothing being thought of as intentionally, but our unconscious biases, as they were more pro-white or anti-black, they were actually less likely to send black patients if the vignette had a black patient to the cath lab, right? To open up the artery, save a life, save heart muscle, even though they diagnosed the chest pain as being from the heart, right? So they diagnosed the chest pain as cardiac. The next step was to go to the cath lab, and it actually didn't send them to the lab to open up the artery and save a life. And so they thought, well, these are really good people with really good intentions. How can we work on this? And so back in 2009 was the first time I'd read this paper, and my mentor showed it to me and kind of set off my interest in this career, because I thought, well, wait, good people are making decisions based on their unconscious values and assumptions, the way we're socialized. I could work on that. So here I am. And so, but it doesn't always pan out, actually. In our grant that was just awarded, when we were writing it, we cited 13 studies about clinical decision-making and implicit bias. And 7 said, yes, it did have an influence, 6 said no. And what it seems to be is likely partly the type of clinical decision-making being made, right? And also the factors involved, like, do you have time? When we have time, we do all the wonderful things we want to do consciously, right? But unfortunately, we often don't have time in real-life clinical care. And so, but this study showed that it also may be the benefit of the long-term relationship, because in this study, there were primary care docs. And Irene Blair and her colleagues measured implicit bias in the physicians using the implicit association test. And as a group, they actually did not show any racial bias correlation or association with outcomes between black and white patients regarding hypertension, right? So then what can we learn from that, right? So that we can continue to tailor interventions to things that work, and for the things that may be having racial and ethnic disparities among others, what can we learn from this to inform those interventions? The communication patterns literature, on the other hand, is robust. Time and time again, racial bias is shown to be associated with communication behaviors. So interpersonal touch, safe distance, length of the encounter itself. This is some really great work done by Lisa Cooper and colleagues where they audio taped actual encounters and had measured physician racial bias and found that there were parameters like verbal dominance, right? So that physicians, as their racial bias, again, pro-white or anti-black, however you want to phrase it, as their racial bias increased, they had more verbal dominance in patients in encounters with black patients as compared to white patients, meaning they talked over them. There was less shared decision making. It was more, I'm talking. And with white patients, the white patients were able to, had more time to talk. And this was, of course, controlled for multiple factors, but there was the association with the actual racial bias. There are a lot more studies, of course. This is in no way meant to be exhaustive. I just want to give a flavor of the literature that's out there. And so, when we try to make interventions to work on this, the purpose of my interventions is not to work on undoing your unconscious. Do we have any cognitive psychologists in the room? There are fascinating experiments in the cognitive psychology literature, but the duration is short. It's very complicated. What we're hoping to do is to help us have that aha moment of, oop, it's happening. It's influencing the encounter in some way. Let me take a step back. Right? Think through this more purposefully, and then deliver the excellent care I wanted to give in the first place. And so it's the action and the behavior that we're looking at, not rewiring our unconscious. I need to always make that clear because there's a lot of fascinating literature out there. And so for us, we think transformative learning theory is the way to do this. And so there are lots of components. Dissertations have been written about transformative learning theory, but the four main components, the first one is experience. So the experience needs to be a disorienting dilemma because the experience itself needs to lead to a paradigm shift, right? A shift in your perspective, a shift from being like, no, I'm a good person, I don't have bias, to being able to be like, oh, bias is part of human nature. Okay, I have it, you have it, we may have different ones, but it's all fine. And so, but it needs to be, you can create it actually for the learners. You don't have to wait for them to experience it, thank goodness. And so you can create it at once. And then that experience needs to be followed by critical reflection and guided discourse, right? Because we don't want to just leave our learners hanging. And so critical reflection, finding meaning in what you're seeing and what's happening. And then as a facilitator, you can guide the discussion. That discussion needs to be profound and deeply moving. So it has to be profound and deeply moving. And then once you've had an experience, kind of had an aha moment, shifted a perspective a little bit, talked about it, found meaning in it, and then you need to the goal is to get to action. Because raising awareness of implicit bias without actual skill development has negative consequences that have been published in the literature. For example, like if you find out you have racial bias against Black people in your unconscious awareness again, right? And then you're like, oh no, I don't want to hurt anyone, but you have no skills on how to mitigate it, right? Then what they found is that people actually start avoiding encounters with other people that they may be biased against with good intentions, but then that kind of separates us even more, right? And so skill development we have a paper in a review that reaches skill development that I'll tell you about, but so fingers crossed. But it's been hard for the field to get there, but that's the ultimate goal, right? And so that's what we work on through transformative learning theory. So let me bring you to a little bit about how we're doing this, and so that hopefully things resonate with some of the work that you yourselves are doing, and maybe spur the conversation that we can continue. This is a framework that I'm about to walk you through that was published by Teal and colleagues back in 2012, actually. It starts at the bottom here. See here for denial. This framework, you can begin on any part of the framework actually, but any individual could be on any part of the framework, but let's pretend you're at denial. Nope, this implicit bias is not a thing. Who invited this woman? Why is she here? Who gave her a job? I've seen evals, years ago there used to be evals that kind of said that. And so you have to meet learners though where they are, not where you want them to be, right? So I learned a lot about the people who couldn't believe I was allowed to speak to medical students about implicit bias in denial. And then from denial you move to defense. Well, fine is a thing, but it's not me, I'm a good person, right? Because it goes against our identity of good people doing our best to take care of other humans. It's a minimization of fine, maybe, but it's not really, it's not going to influence my clinical encounters. If you think about those of you who remember the anti-pharma movement when it was just like, the pharmaceutical reps, they're banned at Montefiore. It's the only place I've ever been faculty, so I don't know how it works at other places. But it would always be like, well, no one with a bachelor's degree could influence my practicing, right? By giving me a pen or a vacation, but it was kind of that, like, sure, it's a thing, but it's them, not me phenomenon, which is human nature to feel a little bit defensive about. So that's how I feel like implicit bias can be sometimes. I talked with Bob Goodman, who had a lot of like the no free lunch movement back in the day, and he really helped me understand how it's a lot of that, of sure, fine, it's a thing, but not me. And you can help people get to be, it's all of us, to acceptance. It's me, it's a thing, I want to learn some skills. And then adaptation, so then the first four, you could probably do in one seminar if, you might be able to do it in one seminar. Adaptation and integration take more time. And that's where you need, I think you need multiple sessions, and the authors advocate for that as well. Because adaptation is, okay, fine, it's a thing, I might be doing it might be influencing my care, and then you can get skill development that you're still kind of have to be conscious about, right? Like, oh, it even happens to me sometimes. I'll see a patient and I'll be like, oh shoot, it's happening. I'm feeling uncomfortable, gotta get the skills that I just wrote about, like, and use them. And this is what I do for a living. so it's a challenge, right? But I'm still conscious of the skills that I'm using. I'm adapting my behavior, right? So then integration, which is the ultimate goal, which just becomes part of our daily routines, right? And so that's the framework of getting a learner through implicit bias instruction over time, of course. And so thinking about that framework and thinking about all the literature, we decided, and the fact that there is no established curriculum, there's no best practices to follow, just kind of pick up off a shelf and adapt for your institution. We did a very comprehensive needs assessment. And so we did focus group studies of patients. We did a separate focus group study with students, right, our intended learners, patients being our intended beneficiaries. And I did one-on-one interviews with the faculty and learned that all of us have some hang-ups about teaching about this, which we'll discuss. I'll just take you through these briefly, kind of big picture things, so you can see what went into the work. And so this is one of those slides where, you know how I've done it, where you'll have a professor who's like, this is a really busy slide, I'm really sorry. And you're like, well, why'd you put it up there? I'm not sorry. So it's up here on purpose. So this is perception of bias in the medical encounter. Perception, not actual. I mean, maybe actual too, but perception. And then, wait, elephant mouse. Patient lived experience, and all this stuff goes into it. We streamlined this for the manuscript, but when I'm talking with audiences, I like to keep it in this form. So we have perceptions of bias in the medical encounters from our patient focus groups. Patient lived experience, all this goes into it, systemic racism, life stuff, all kinds of things, previous treatment experiences, and then here we are. Ta-da! Just one tiny little box in this entire mishmash of life experience. And so then I feel like at this point, people are definitely like, why? Who invited her? Wow. How are we supposed to address this? And so stay with me. So I'm going to blow up this bottom half for you, okay? So once the bias is perceived, or if bias is perceived, two things happen. So if bias is not perceived, I'll take right on the left-hand side, you've got continued engagement in healthcare, increased trust in physician. If bias is perceived, if the perception of bias is present, that's where the skill development needs to lie. Because the problem from what we learned from our patient focus groups is if we ignore or dismiss it. Right? And you know how to, you speak with patients, you speak with students, you know when things are going well, and then all of a sudden things are not. And you're just like, and sometimes you just are like, oh, I don't know what happened, but man, I'm gonna barrel through to the end and get past this encounter. And other times, it may be that in the case of implicit bias, they may have perceived bias. So if it's ignored or dismissed by the physician, you have patient mistrust, delay in care, and avoidance of future care. And I'll give you some examples in a second. If you recognize it, right, taking us to the middle box, so if you just recognize and acknowledge it, focus group after focus group had, yeah, it's fine. We know people are human. People make mistakes. There's continued engagement in healthcare. And I'll give you some examples. So I had a colleague who had who's a reproductive endocrinologist and had a patient who was Latina. And my colleague asked her, she was married to a man, so she was like, does your husband have any previous children? And the patient got so pissed. And like, why are you asking if my husband has other children? Like, and my poor colleague was like, Cristina, like, what happened? And meanwhile, asking if the male partner has other children proves previous male fertility, right? So it's a standard question. But other patients may have just been like, oh yeah, no, or oh yes, or whatever, but not taken offense because they may not have the lived experience of negative stereotypes of unwed mothers and all kinds of stuff. So in that moment, you can imagine the physician's like, you know, what's going on, right? Like the patient's like, why are they asking me that? And that's the opportunity to have that aha moment of, oop, sure, I asked a standard question, but all that life experience led to perception of bias, right? And then you don't have to take it personal. It's not your fault. And what I encourage, what we teach to this exact target. We teach so you can develop language. So I would say something like, I'm sorry, I should have led with, we ask all of our patients this to see if there's any proven previous male, children, fertility, men being able to make children, basically whatever layman's terms you would put that in, right? I'm okay saying I'm sorry, even if it wasn't my fault. If you're not okay, then you develop your own language. Like, I should have led with whatever. And so, or you can imagine a young man coming in with a sports injury, and you're asking about tobacco, alcohol, and drugs, and they're like, "Why are you asking me if I do drugs?" But if they're being, if they're, for example, a young black man who's followed around in stores, you might be like, they may be covertly or overtly accused of wrongdoing all the time, and they're just like, "What's wrong with you? I'm just here, for my injury." And then you can imagine, especially a junior learner, being like, why did I ask you? Because that's what they told me to do, And then everybody gets frustrated. So this, I think, I got to tell you, I still remember the feeling when we got the first focus group be like, just apologize. Because we were like, what do we do? What do we do when this happens? And it was brilliant. And they had because the focus group study, the real contribution to the literature was their perspectives on potential solutions to restore the encounter. Right? The fact that they perceive bias has unfortunately been written about over and over and over again, but their perceptions and their ideas to solve it, to restore the encounter, was just eye-opening. So I'm eternally grateful. And so so here's one place where we can teach, right? And this comes from the opinions of our intended beneficiaries being our patients. This is another busy slide that informed our from our student focus group that informed the way we teach. And I just want to highlight up here the cognitive dissonance created by the hidden curriculum. But really, for the purposes of this talk, it's just that there's a lot going on for our students, and we have to meet. This was medical students, but I suspect it's similar across learners across the continuum. There's just so much going into it, and this was published in JGEM this past year, and so we need to remember to meet our learners where they're at. Right, and get them to where we want them to be. And that was a lot for me to learn too, as opposed to want them to be where we want them to be. And this last study is from the faculty interview study, the last figure. And again, it's I leave it busy and I leave it up because up here is perceived facilitation ability. But what I want to draw your attention to for the purposes of this talk again is not so much the details of what went into this, but all of these arrows. So all of these arrows are bidirectional, and everything interacts with everything else. So faculty resistance, personal factors, and institutional values, opportunities for faculty development program. And what this one and the previous model helped us realize is that if we could just layer both sides with empathy during the instruction part of it, right? Like the facilitators, the students, and we could kind of work in the middle to meet in the middle together, I think a lot of the emotional charge could be we could help each other through it, and then be able to have open and productive conversations about it. And so that's why we do this work. That's how we got to this work, and that's the needs assessment is the big frame, the big informing to get into our transformative learning theory as an explanatory framework. And so how do we do this? Remember that we're going to focus on the four main components of transformative learning theory, and so we create experiences, that paradigm shift I told you about of transformative learning theories. We talk about patient lived experiences. Some of you may have patients that come and speak with your students. We talk about resistance and shame from students and faculty. We make sure to, in our discussions, be cognizant of the fact that there's going to be resistance and shame from students and faculty, and teach about the patient lived experience, but also remember that patients are maybe have bias about us and us about them, and teaching encounters, whatever you will have you. But the paradigm shift can be very moving, can be very profound in very short amounts of time, right? And so the paradigm shift, the experience of it, will also help with that resistance, right? So we'll also help with the resistance of like, not me, not me, not me. If you can create a safe, and I'll show you some examples, if you can create a safe exercise, right, where people go through it and it's like, oh, yeah, me too. And the people that have shame, where they're like, I don't want to be this, I don't want to have these feelings, etc. When you normalize it and are like, it's human nature by the way we've been socialized, all rooted again in systemic racism, the way media portrays people. That's a talk for a different day. But because it's human nature, even though it's not our fault when we've been socialized like this, we can adjust our behaviors, right? And that's what this work does. But creating that experience really helps them get the patient perspective, helps overcome resistance, and helps students that are feeling shame. And then all the other components, right? The critical reflection, guided discourse, and the actual skill development will help learners through that framework that I was just showing you, right? From denial all the way to integration over time and practice. It will help with the unintended consequences of awareness without skill development, right? Because if you give a chance to practice things with active learning principles, then you feel empowered, right? And there's also the social cognitive theory, where you can have increased self-efficacy through having the vicarious experience of someone else succeeding, right? We're about to talk about that. And so that can help with the unintended consequences of just having awareness without actually getting skill development, because they can also see each other succeed. And then it can compensate for learners' discounting of the instruction, right? So creating what's called a critical incident. You might have a standardized patient case where, I don't know about the things that you teach, but some of the stuff that I teach about, people think it's quote unquote common sense, right? Like culture, like think about cultural sensitivity, cultural humility. Before it was called cultural competence, people were like, yeah, of course, we get it. This is soft, it's fluffy, it's not, it's common sense. But if you have exercises where you can create what's called the critical incident, where people can go through them and in essence fail safely, right? Then you can have that moment of, oh, okay, this isn't common sense. I have to learn a skill just like everybody else has to learn a skill. And we have found that standardized patient exercises have been helpful and I'm sure many of you have used them in various aspects of at least communications, right? Where you might throw something in and we have one where we do it with social determinants of health, where people are just pushing the meds and pushing the lisinopril and really it's that finances have changed, and so they're buying cheaper, saltier food and going into heart failure over and over again. And it's great because now it's like, oh, and they can think about it, and it's okay to not get it right together, right? So the educational strategies, to give you some actual tangible examples that we use. So for the transformative learning theory, for that experience component, right, that paradigm shift, that aha moment, we use first thought exercises. We use the implicit association test. We use perspective taking exercises and video observation, which I will show you. We'll have time. And so we want that aha moment. Here's a first thought exercise. Can you just project it to the back? What is one word you have heard about people from the Bronx? This is a screenshot from a poll everywhere, like an audience anonymous response system, and that I do with my first year medical students in our, there's like a 2-hour seminar we do with all of them, right? And so for the first hour, they have me, and then they have a small group for the next hour. So using poll everywhere, the question comes up, what is one word you've heard about people from the Bronx? And people type, and you can, of course it's anonymous, the more that type the same word, the bigger the word becomes, right? And so why I like this as an aha kind of moment is that we talk about, you can see some of the bigger words are poor, ghetto, dangerous. And so we also talk to them about, I'm leaving this up too long because everyone's trying to find the word. Do you want to know what goat lover is? So yeah, I knew that was going to be it. So I'm not quite sure. No. So I'm actually not quite. It's also weird that this is being broadcast. I don't know if everybody else over there is laughing, but so I'm not sure how Goat Lover got together because other years it's just been goat. So one year goat was really, really big, right? And I was just like, I don't get it. So I'm like all smooth and cool, right? And I go up the stairs and I lean into my like 22-year-old research assistant and I'm like, Natalia, what is GOAT? And she's like, Dr. Gonzalez, it's greatest of all time. And I'm like, oh. And so I don't know why they put that in there. Maybe for the Yankees? I'm not sure. But but there have been other questions we ask and GOAT will come up. Fun fact, it's greatest of all time. Young research assistants are the absolute best. And so, but we put this up, and then the other question that I put up is, what's one word that would describe the community that you come from? Right? And then that part of that aha is seeing the differences between those two word clouds, right? And we also talk about priming and its effects, right? About if you think people are going to be dangerous, you already in your mind before you meet them, you're very likely to act differently than if you didn't think they were dangerous. And people say a lot of things about the Bronx. Has anyone taken the implicit association test? Okay, great. In a nutshell, the implicit association test pairs personal characteristics, for example, race, with value-laden words, right? And it's thought, tons of controversy, which happy to discuss offline. But I don't use it as a diagnostic tool in any way, shape, or form. We use it as what's called a provocative trigger, like to get the conversation going, right? So it's not like I'm like, well, you were 2.0 and you were 0.35. No. And so, but I'm going to take you through what it would look like. So people take it. So you see, this is, if you do the race one, it's African American and European American, and you have to click the I and the E key based on what is on which side. So there's our practice, look at these people, then you practice with the words, bad and good. The words are very dichotomous, like it's like hurt, joy. And then they're paired. See the in the top corners, the African American's was paired with bad and European American is paired with good. And you have to put either the face or the word and pair it with the correct side. And the faster you pair one set versus another is thought to be a measure of your implicit bias. If you make a mistake, that happens. And then you see up here now they're switched. So European American is now paired with bad, and African American is paired with good. So whichever side you do faster. And this is hard for people. They don't like this. Oh, there's tons of different things. I talk about race, right? Like race and ethnicity is the focus of all my work. But because we're working to have that skill set of that aha moment of, oop, things were going great. Suddenly we have a change in the rapport, the encounter, right? More research, of course, has to be done, but we expect that the skills themselves should be transferable to different kinds of biases, right? Because why would it saying, I'm sorry, I should have led with work for race and not for gender, right? Perceived bias, right? And other kinds. And so anyway, there's a ton of different types of bias you can have, and you can go on this. Nobody probably goes on it as much as I do. And so taking the IAT can be an eye-opening, before I get to that, is an eye-opening exercise. And I also think it's very important to guide your learners through it, right? To make sure that they're okay. We take perspective taking exercises. So these are 2 videos from, they were actually made by the young people in them, right? So they're like on YouTube. And this has been wonderful because the students love it. It's not a bunch of like faculty. I don't know about you, but I don't really have any acting skills. So I can't recreate like a de-identified scenario very reliably on a video, right? We'll do them in role plays, but not in a video. And they love it because it's authentic, right? It's authentic. It's people's real experiences. It's young people. And so this is a young man who's being followed around the store, like I was mentioning earlier. And this is on the right is a woman who identifies as femme, and she tells a story about the repeated trauma of having to come out, right? Over and over and over again in safe spaces, in LGBTQ spaces, and how nobody believes her, and how she's too pretty, and it's all her words and her experiences, and it's very moving. And a lot of the unifying parts of perspective taking exercises is that people get, this young man has to prove he's not stealing candy at the convenience store. This young woman has to prove over and over again that she's lesbian, and that people keep questioning her actual reality and identity, and it bothers both of them. There's lots of other videos you can use, but that is a nice thought to think about, a nice introduction, to think about, like, imagine if you were constantly having to prove your reality. How might that change your behavior as a patient, right? Or like, if, for example, if you're a patient who nobody ever believes you're in pain, maybe by the 10th time you went to the hospital, or the 4th, you would act more, you would advocate for yourself more, you would act more quote unquote aggressively where somebody else may not be perceived as aggressive, right? If you already know they're not going to believe that you're in pain. For example, which happens to a lot of our patients with sickle cell disease, for example. So this is good as a non-clinical example, and then the clinical tie-in. We are going to play, it's only a few seconds.
On top to stay, Hey!
Think I'm gonna steal your car?
No, I forgot to just put the alarm on. It's not you. It's no race thing. No race thing. Asshole. No, I don't even need the alarm on. Look, here, it's off. I turned the alarm off. Look.
Kind of breaks a little bit of the tension. Thank you so much. That can happen. And so I showed this video because I think it's a real life example of something that could be perceived as bias. So from Curb Your Enthusiasm, right? So Larry David's character, he's he's the main character in the show. I've actually never seen the show. I used to clips all the time. But, how many of us have hit our beep or our alarm button feet away from our car, right? And so that's, let's say, that could be analogous to asking about the male fertility, right? The question like that, right? But as the black man walks by, he may be covertly and overtly being accused of stuff all the time. People cross the street. People clutch their purses. Like, I have a friend from my college, we both went to the same college and we're good friends. He makes a ton of money, and he's Haitian American, and he drives a Jaguar. And one day, somebody like hit their alarm on like a Ford Escape, like really a lot of times as he was going by. And sorry if you have a Ford Escape, I drive a Subaru, so I'm not fancy. But I remember he was just so pissed. Like, really, dude? Like, really? Like, and so it happens, right? People get crossed the street on all the time. And so I show this as like and then we talk about the perspectives of both sides, right? And so you can imagine Larry David's like, no, it really wasn't. And if that were an encounter where those two people, if a clinical encounter or a teaching encounter, how could they come back together, right? So that's just a way to show this happens all the time. And so then moving to the next two components, right? The critical reflection and the guided discourse. We can talk about etiologies of bias. I have people do personal narrative exercises, right? Where you grew up. I love these because you have some time to reflect where you grew up, how you grew up. A lot of this gets built up in our communities, in our families. Clips from pop culture, like I just showed, and other media outlets. This has ruined all of TV and movies for me because I'm always like, oh, look how they're being portrayed. Why's he got to be the bad guy? So it ruins a lot for me, but it seeps into our brain, right? And you think it's gonna be people. I'm always floored by how much we actually think it's how it's gonna be. One of my colleagues moved from the Philippines when she was 15, and at the time she was 15, the movie Clueless. So I'm showing my age. She's even younger than me, and so Clueless was out, and when she just thought everybody in America lived in mansions, and I was like, oh. I must have been really disappointed. But that was like her only exposure to American culture. And so it's a cute, funny movie, but it's interesting to see how just watching a movie can really, really get your perspective. And that if you don't have anything to challenge your perspective, right? Or challenge you that maybe you should accept that it's not even a perspective we should be having, that is just gonna guide how you act and think and behave. And then narrative writing. We do a lot of reflections on bias in oneself. We talk about things. I happen to love Zumba. It's like my thing. And there are plenty of stories of assumptions you make when you line up in class, especially when there's a substitute teacher. So I freely share them. And the students also appreciate that role modeling, right? Of being like, oh, she's a work in progress too. Right? I never come to audiences, and I hope you haven't gotten that perspective from me of like, hello, I know things, and I'm going to fix you on your bias. We're all in this together. And so we talk about unanticipated reactions, right? Then we talk about potentially witness bias. This gets more into the clinical classroom or the clinical setting or the classroom. So things that they see on the wards. Even first year students, in your introduction to doctoring course, whatever your analogous courses, will be seeing things. And if we talk to them about bias, but then don't have any ways they can manage up, if you will, it really puts them in a tough spot. And then we talk about the experience of taking the IAT and the results. And so let's talk about action, because I just finished saying, if we teach them about bias, but we don't empower them with any kind of skills, they're going to see it, right? Kind of like when you want to buy a new car. If you want to buy a red car, you suddenly start seeing all the red cars on the road, right? They were there the whole time, but now they're in your sphere of awareness. And so if I teach them about bias, like in the first week of medical school, and then we have no follow-up, then they're just either, I'm sure some of them have learned about it too in lay press and college, but if I teach them about bias and I have no follow-up, then they're just going to see it and not know what to do. So we practice articulating statements for hypothetical scenarios. So I talk about scenarios where oftentimes from my real clinical experience where either bias has been perceived or I've absolutely made an assumption and messed up, right? And we talk about that, and I'll be the attending in the scenario, of course, because it's and then they practice articulating statements, and I think practicing articulating statements is very important. Not just like what would you do, right? And then you're like, oh yeah, I would totally ask the attending, why are you saying that, right? It's harder to actually do than you think. So I call them verbal procedures. Right, just like you would practice putting in a line, we practice actually articulating statements out loud. And these are our verbal procedures. We do role plays where they're in the hot seat. And we talk about, so I have 3 role plays that I do. This gets into my elective. So as I said, I've got some things that are in the compulsory curriculum, but that's gotten to like awareness, knowledge, reflection, and strategy identification over 2 sessions. But what we've piloted in the elective actually has worked, at least in the self-selected. Of course, it needs to be tested in all comers, but getting actual skills is absolutely doable. And so we've got role plays where this is the 4th component, right? The action component of, up here, of transformative learning theory, right? So we do role plays. The student is in the quote-unquote hot seat. Everybody else has a semi-scripted role, right? I always play the faculty member, and but the student in the quote-unquote hot seat has no idea what's coming at them. And the participants are participating and observing, and the observers observe, like in a fishbowl format, right? And so we debrief it using the format that was created by Kelly Scaffinger Jet Stratos at Stanford for their Faculty Development Center for Medical Teachers. I'm sure some of you have gone through that program. And they gave me permission to adapt it. And it is phenomenal because you'll have, the 3 scenarios are small group mentoring, like career mentoring kind of thing, where, the woman wants to go into surgery and someone's like, really? Like, do you want to have a family? And I do that because my orthopedic surgeon teaches medical students and says that he asks them about their career aspirations. And when he asks women about do they want to have a family, he's like, if looks could kill, I'd be dead. When he asks the men, they're like, oh yeah. And it kills him inside. He's like, I don't know what to do. And I suggested he try to just do it with everyone together. Right? Like have some sort of, you can do one-on-one mentoring, but have some sort of session where you could just be like, well, you're asking everyone. So it seems like, so you are asking everyone. Because again, that lived experience of, suddenly because I'm a woman, I can't go to a quote unquote busy surgical subspecialty. Everyone's busy. So I do that. And they work on asking, why are you asking that? And kind of questioning the attending. But there's a step-by-step debrief that we do following that format. And then there's a do-over. And we've done focus groups to evaluate the elective over the 3 years. And I'm not in the focus group, of course, because of the power dynamic. But when I read the transcripts, one of the students was like, that do-over is a real gift, right? Because they get to leave on a successful note. It's Bandura. I'm sorry, I quoted the wrong person before. So Bandura's theory about where you can have the increased self-efficacy where you have based on the vicarious experience, right? And a well-created role play, you can suspend the artificiality and really get that gut reaction. And so we have that one. We have one which is de-identify from something that actually happened about obesity and Hispanic parents not caring about their children, and because they're obese children is what the role play says, and also that somebody once said, a faculty member, that women in the Middle East have higher rates of obesity than the men because they're not allowed outside, and the students came to me and didn't know what to do, and so we created a role play, de-identified. I mushed some things so you can't tell who it is, and they're able to practice just calling attention to it. You may not change the faculty member, right? No one's presenting that one question is going to change me into never making a biased statement. But they feel that they can advocate for either the patient or that really you should be saying these things about Hispanic parents don't care about their children, et cetera, et cetera. It helps them with that cognitive dissonance I was telling you about, that uncomfortable feeling where their actions weren't matching. It helps them there, and it helps them. Maybe little questions over time will help the faculty member, but it will also help show the other students in the same level of training that this isn't something that's accepted, because that was the other problem. Students are like, is this the way things are? Like, is this the way things are supposed to be on the floors, or is this bias? And then that's another way to address that part. And then the third one is a operating room role play where disparaging remarks are being said about the unconscious patient. So in this upcoming grant, we're using standardized patients and virtual patients, the one that was just funded. And so stay tuned. But if you can practice with standardized patients, as I'm sure you all know, also serves as an assessor, right? They're also watching you and I don't want to say grading you, and these would be formative, of course, at first, because we want to learn these skills. None of this is meant to be punitive in any way, shape, or form. And then virtual patients is one of my sub-aims. If we can get a virtual patient case going, then you can manipulate the characteristics of the patient itself, right? You can reach areas that may not have a diverse standardized patient pool, and you can capitalize on what's called the aversive effect of private hypocrisy, meaning that like if you are like, oh no, in real life, you're actually more likely, in private, you're actually more likely to change your behavior in real life. Rather than kind of getting called out in front of everyone, then you're going to get defensive to save face, if you will. So those are our upcoming things. And then for assessments, we have reflective writing rubrics. We made an attitude assessment instrument, not about your action, like not testing what kind of bias you have, but your openness to learning about it. We'll be using checklists and global rating scales, and my RO one, God willing, will be unannounced standardized patient visits, but that's some years away. So in conclusion, transformative learning theory can be our explanatory framework, but it's also just a real tool to inform instructional design, right? So think about it as just scaffolding. And if for any kind of emotionally charged topic you may be working with, I find it to be a very helpful scaffolding tool to hang my strategies on. And hopefully some of this has helped you too. Thanks.